Good afternoon, everyone. If you haven't done so already, I'm going to invite you to mute yourself, and please don't take it personally if I mute you. During the presentations, enter any questions you have into the chat, or you can ask them out loud at the end of the presentations. For those of you on the phone, if you're not already on our email list, my email is efield, that's EFIELD, at usetinc.org. You can email me and I will make sure you are added to our email list and get the recording of this presentation after the call today. Towards the end of the call today, I'm going to share an evaluation link in the chat. If it does not highlight, because there's some weird Zoom updates these days, please just copy and paste it and give us some feedback on how these are going. And that is all. Oh, we will be recording this session. It already is being recorded.
Great, thank you. So we'll start today with Taloa giving staff presentations of those that are presenting. So Taloa.
Hi, so today we have Christy. She's going to do some surveillance updates, and then we're going to go to Jorge Mera for some COVID updates, and then finally Imani Ransby will give us an update on contact tracing. We can go ahead and get started with Christy.
Good morning, everybody. Do we have the slide deck?
I'm pulling it up right now, sorry.
Okay, no, that's okay. So this will just be a very brief overview of the testing that we have, the information on testing that we have in the Nashville area. Next week, I will have a prevalence graph of the cases in the CHSDAs that we've been pulling from for each tribe's CHSDA. We've been reporting to them weekly. We wanted to see what that rate looked like on a USET aggregate level. However, we ran into a glitch into our Excel spreadsheet that we can't figure out. So as of right now, those data are incorrect. So we're not going to share those until we get that figured out. So as of right now, we've got 27 sites reporting, and that does include some urban centers as well. We had 3,465 tests conducted, and that's up from 2,798 last week. We had 312 positives, up from 224 at this time last week, and we had 2,873 negatives, and that's up from 2,277 from the previous week. So it looks like most of the sites are doing a really good job on testing. We are getting an increase in positives. However, I will say, in my opinion, across the USET region, 224 to 312, well, that's about 80 cases, 82 cases. That's a good number, but it doesn't seem to be just real concerning at this point in time. However, we do know from the call yesterday, the joint call, that Choctaw is having a real problem with cases in their community. If your community is also noticing an uptick in the number or the rate of cases, please let us know. We are tracking this on a daily basis, but we are pulling that from the state departments of health websites and looking at the CHSDA counties. So the numbers that we have as of right now are not tribal specific. So if you are noticing something, please let us know. Go ahead and go to the next slide. As always, I just want you to keep these questions in the back of your mind. We're really trying as hard as we can to offer both assistance to all tribal nations on a USET level, to make general recommendations and provide general guidance, but also to provide tailored technical assistance. So we're always looking for feedback. What tools can we provide or improve upon? What are your greatest challenges during this pandemic? Where do you feel most supported, and where do you feel least supported? And that helps us just to better guide how we approach things and the information that we give you all. So if you ever have any thoughts regarding this, please feel free to share it either on this echo session or in an email. I just want you to keep these questions in the back of your mind because they're kind of guiding how we provide our technical assistance to you. So with that said, I'm going to go ahead and turn it over. Dr. Mira? Dr. Mira is up next.
Yes, thank you.
Thank you.
Okay, so I'll have some treatment updates and then some other miscellaneous updates. So the first thing that I wanted to share with you is this website. It's the American Society of Health-System Pharmacists Evidence Assessment. And basically it's pretty, it's really cool because on the left-hand side, they divide all the pharmacological agents that may have activity against COVID-19 into antiviral supporting agents, which most of them, if not all, are anti-inflammatory agents, and then other, different types of categories. And when you click on any of the drugs, for example, if I had clicked on famotidine, it pops up the name of the drug, the type of drug, what is the rationale for even trying to consider this as a COVID-19 treatment, then the clinical trials that are ongoing or the ones that, and if there's any results, they will put it there. Then the dosage, and then the final comment, which is if you're like in a rush, just go to the comment because it'll tell you this, how well known the information is on this drug. So you can do it for any of them and it's updated. And NIH has a similar one, which is also good, but I ran into this one and I think it's a good resource. So this article was published in March of this year. And I thought the concept is very interesting, which can give us some insight in the treatments that we have available or the ones that will be coming. When would it be the best timing to use them and as a concept? So the bottom part of the graph is not up to date. I mean, anything in COVID that's 1 week old is too old. But so I wouldn't pay attention too much to the drugs, how they classified them, but yes to the chart itself. So when you get infected with COVID-19, the first 7 or 8 days, you're basically, the human body is actually giving a response to the viral infection. And that's when you see a lot of virus detected in the PCRs in the different body fluids that you may be testing. And usually the symptoms that the patient presents here are either mild, usually fever, chills, they may have headache, myalgias, a dry cough. And the labs are usually lymphopenia, increase in LDH, D-dimer. But then the patient will transition into a pulmonary stage in which they start having shortness of breath. And the 2A and 2B classification is to divide them into hypoxemic, it would be 2B, and without hypoxemia, it would be 2A. And then not all patients, but about 5 to 15%, depending on the statistics that you're looking at, will develop a cytokine storm, which makes inflammation worse, specifically in the lungs, but not exclusively in the lungs. This is when the patients that do not do well will end up with ARDS or shock or cardiac failure, and you will see a really impressive elevation of inflammatory markers, including CRP, IL-6, ferritin, and other markers, depending on what you're measuring. So if you have a drug that is an antiviral, like remdesivir, it makes sense to use it early because that's when the virus is replicating and the drug has activity against the virus itself. When you're using medications, and I'll just use an example, steroids, although they're not recommended, but if you were going to use an anti-inflammatory agent or an anti-interleukin drug, which some are being studied, and I'll show you some information, probably this is when the patient starts with the host inflammatory response. That's when these drugs probably would have more effect. And I'll come back to this later. So I'm going to show you some interesting studies. Of course, none of these medications are approved, but this was a trip. So these researchers combined interferon beta-1b with lopinavir, ritonavir, and ribavirin, and they compared it to the control group, which was lopinavir, ritonavir. So this study was done in Italy. I believe it was in Italy. I could be wrong about that though. And at that moment, their standard of care was lopinavir, ritonavir. And I mentioned in previous talks that the only published study regarding this combination by itself did not show any improvement. So you're really not knowing here if the control group was actually a placebo group if this drug doesn't have any effect. But that's how it was designed at that time. And what they saw is that the patients who got, in addition to the lopinavir, ritonavir, they got the interferon and the ribavirin, the nasopharyngeal PCRs cleared sooner, 7 days versus 12 days in the control group, and they had a higher resolution of symptoms and hospital days. But many of these patients, or most of them, had mild infections. They did not have severe infections. So this is promising, and more studies are going on, and we'll just have to wait and see if this is an option in the future. The other one that I found really interesting was this interleukin-1 blockade with high-dose anakinra. Anakinra is a monoclonal antibody against interleukin-1 in patients with severe acute respiratory distress syndrome and hyperinflammation. This was a retrospective study, and this one happened in Italy. And what was going on is that in Italy, they were out of ICU beds, so they had to place patients that were already developing ARDS in a non-ICU environment because they did not have enough respirators or to start these patients on mechanical ventilation. And these patients were dying. So using more or less the concept that I gave you on the previous slide, they said, okay, this is the phase where these patients are having the cytokine storm. So why don't we see if using this drug prolongs or gives them a little bit of time for them to get an ICU bed. So they did, the control group was historical, but the week before. So for 1 week, any patient who was 18 years old or older, who had moderate to severe ARDS and who had hyperinflammation, specifically defined by CRP of greater than 100 or ferritin greater than 900, they were managed by their standard of care. And the following week, they introduced this drug to the patients that were in the same category, but 1 week later. And what they found is that the ones who received, the ones who received the anakinra did a lot better regarding survival. And this was statistically significant. You can see on the red line, the high-dose anakinra. And I want to mention, they started with a low dose for about a few days, and the low dose did not seem to work, so they just jumped up to a high dose. And the results that are explained in this chart are only with high dose. So the high dose compared to no anakinra, the survival rate was statistically significant. Basically, 92% of those patients who received this drug survived versus 56 or 58% of those who did not. When they looked at need for mechanical ventilation, although there was a percentage difference, it was 70% of the ones who received anakinra did not require it versus 50% of the ones who did not receive it. It was not statistically significant. Nevertheless, what they showed that this drug seemed to have an impact on mortality in this patients with severe ARDS. And that prompted a randomized double-blind control study that's ongoing right now. A little bit more on hydroxychloroquine, and despite the fact that some of our leaders are taking it, even prophylactically, it doesn't seem to work. So this is the study that was done in New York, 1,400 consecutive patients with COVID-19. and they received hydroxychloroquine. Then they compared it to the group that did not receive hydroxychloroquine, and this was stratified and adjusted by age, gender, and comorbidities and other medications the patients might be getting. And they looked at specifically, the endpoint was need for intubation or death. And what they found is that there was no difference between the hydroxychloroquine group and the other group. And although this was not a randomized, double-blind, placebo-controlled trial, it adds a little bit more of data to the one that we saw from the VA, from China, and for most of these places that they're not finding any differences in outcomes with this medication. So this is the same study. 1,446 patients were admitted. They had to exclude some because they were intubated on day one, so they did not fit their inclusion criteria. They ended up analyzing over 1,300. And here you can see the probability of not dying or not being intubated. In the blue line, no hydroxychloroquine, and the red line, hydroxychloroquine, and the shaded area is the confidence intervals, and there's no difference, statistically speaking, between the drug or no drug. Switching gears a little bit, we know, based on many reports, that patients with COVID-19 have elevated D-dimers and have a higher risk of thrombosis. And these thromboses are mainly venous, but it can be arterial too. In a Dutch ICU study, 184 patients who were admitted to intensive care, 31% had thrombotic complications. 27% of these were venous and 3.7 arterial. Then there was an autopsy study that also revealed that all of their patients had clots in their pulmonary arteries. So, confirming that clotting seems to be a problem. And actually, there's a new study that came out yesterday in New England that I'll probably present next Friday, looking into more detail into the pathology of COVID versus other viruses that cause ARDS. And a multi-center observational study of over almost 3,000 patients, they looked at of those patients who were on full anticoagulation, that they fared better than the ones that were not. So it's not that they started full anticoagulation because they had COVID. It was, for example, a patient who was being admitted because they had AFib and COVID, and because of their AFib, they were on full dose Coumadin or whatever other blood thinner they were using. And what they found that when they looked at the group overall, there was no significant association between full anticoagulation and hospital survival. But when they looked at the 395 patients that required mechanical ventilation, the in-hospital mortality was 29% for those treated with anticoagulation, compared to 62% of the ones who were not. So there may be a role for full anticoagulation on patients who are severely ill with COVID-19 and admitted to the ICU unit. I know that some places in New York and other cities where they're having a major impact due to COVID-19 are doing it, and empirically, this on their best judgment. But hopefully there will be some studies clarifying this. Definitely everybody should be on a DVT prophylaxis, standard of care for any patient with an inflammatory condition. The question is, should they be fully anticoagulated or not? And this is this is the autopsy series that I mentioned, in which they found a lot of patients with DVTs and also pulmonary clots. On the right-hand side, this is interesting. So in the UK, 200 patients with severe COVID-19 were evaluated to see what was their activated partial thromboplastin time, or PTT. And they found that 20% of them was prolonged. But in 91% of these 20%, it was not associated to bleeding, but they did have what's called a lupus anticoagulant, which is an abnormality that we see in other subset of diseases. And the importance of this is that if someone with COVID-19 gets admitted and they have a prolonged PTT, think that this could be a lupus anticoagulant, and that could be determined in the lab. And you should not withhold anticoagulants because their PTT is prolonged. You should go ahead and do the partial or full anticoagulation based on your judgment, but this laboratory result should not deter you from doing it, at least in the majority of patients. So going back to our graph of the different stages of COVID-19, going from viral response to a pulmonary stage to a cytokine storm with a hyperinflammatory phase. Right now, we only have remdesivir and convalescent plasma as recommended therapies, not approved by FDA, but recommended in emergency situations. And actually, remdesivir, it does have an emergency approval, but it's not fully approved. It's still an investigational drug. But if you're going to use the antiviral, you probably need to use it earlier than later. Right now, the indications is that the patient has to be at least hypoxic, so you should only be using it on patient category 2B. But I have the gut feeling that this is going to be changing. If this drug actually works, it makes more sense to use it earlier than later on patients who are hospitalized. Convalescent plasma, you can give it anywhere, but again, the mechanisms we assume them, you're blocking the spike protein of the virus probably and preventing it from infecting cells, but it could have an anti-inflammatory effect also. But if you're going to use it, also I recommend that you use it earlier than later if you're going to use it at all. In our hospital, we indicated now anybody who gets admitted to the hospital who has high risk factors, meaning age or comorbid conditions, we offer the patient convalescent plasma. We explain that it's investigational, but we make a decision. We share the decision with them, of course. Anti-inflammatory agents, they're all under clinical trials. There's no one that you can really use, but if any of them pans out, like the anti-interleukin-1 or IL-6, there's a bunch of them out there being tested. Probably the time to use them would be on phases probably 2A or 2B if you need to use them. And then anticoagulation, prophylactic would be indicated in anybody who gets admitted to the hospital because they have an inflammatory condition that puts them at high risk for thrombosis formation. And the question is full anticoagulation. When do you use it if you use it at all? The answer is not out there yet, but probably if it does have an effect, it will be on patients with severe disease, probably phase 2B or stage 3. Okay, a little bit about COVID and animals. And this came up, we're not paying too much attention to animals and COVID-19, but there's been some reports. And one of them was published in the Science magazine in in April. And basically they experimentally tried to infect different animals, including dogs, pigs, chickens, ducks, ferrets, etc., and through different ways. And what they found is that cats were susceptible, as well as ferrets, to COVID-19 infection, and that cats were susceptible to airborne exposure. And then in New York, there were some publications of 2 cats that were found in someone's house that had COVID-19, and the cats were infected and actually even symptomatic. And then there was a report in the Bronx Zoo that the tiger had been infected, and I believe there was another feline that was infected too. So recently in New England Journal of Medicine last week, it was published, this experiment. So they grabbed 3 cats, they inoculated them with SARS. They co-housed each cat with a cat that was not infected after they'd been inoculated. And 5 days later, they found that all the cats that were not inoculated with SARS, but put to live in the same area where a cat with SARS was, all got infected. Interestingly, none of these cats, although the number is very small, were symptomatic, but that they had viruses. And the authors conclude, given the need to stop the coronavirus disease, 2019 pandemic, through various mechanisms, including breaking transmissions chains, a better understanding of the role of cats, what the role that cats play in transmission is needed. So please do not kill your cat or throw your cat away. I mean, there's very early information, but the CDC has come up with some guidance on what to do with COVID-19 positive patients who have animals. And this guidance basically tells you that when you isolate someone with COVID-19 from other humans, you should also isolate it from the pets. That means avoid direct contact with the pet, including petting, snuggling, kissing, licking, etc. All the things that, all the weird things that we do with our animals. And also, if possible, have someone else in the household who's not COVID infected to take care of that animal. Now, there is an exception. If it's a service animal, then they should be permitted to remain with their owner. The other thing is that in case the household animal needs to be given out to another person or rehomed in an institution for whatever reason, those individuals and the institution should have standard practices on how to take care of these animals that have been exposed to someone with COVID-19. So this is not a joke, this is true. There is telemedicine for pets and animals. So I got this this picture from actually a veterinarian service advertising that they were doing telemedicine. And the CDC also puts it as an option. So if your pet gets sick, first you need to notify the veterinarian that this pet is coming from a household in which there's a COVID-19, so they take their precautions. If your veterinarian offers telemedicine, that could be an option too. And for veterinarians, there's also detailed recommendations. If they receive an animal that has been exposed or has symptoms compatible with COVID-19, they should contact the local state health department to get guidance on how and when to test the animal. This is switching gears a little bit, this is a study that came out from Georgia. They looked at hospital admissions for COVID-19 in several hospitals. And what they found is that most of their patients had a median age of 60 years. And the median age of the population was 60 years, that most of their patients were less than 65 years old, 62% of them, and that the majority were non-Hispanic Black, which in a higher proportion than admissions for other reasons in those same hospitals. So there was an overrepresentation of African-American population. The 26% did not have any underlying conditions, and a very big proportion of them, almost 40%, got admitted to the ICU. When they looked at mortality on the right-hand side, there was not a higher mortality on African-Americans compared to the other population. They were just overrepresented, and that probably means that more intense interventions in the community should be made, especially in the African-American population, because for some reason, they probably are getting more infections than the non-African-American population. And last, well, I don't think this is the last one, but this is an interesting, very long and detailed study. It takes a while to read, but it's fascinating because they looked at the epidemiology and risk factors for acquiring coronavirus in healthcare workers. And they looked at all the coronavirus data from SARS-CoV-1 in 2003, from MERS in 2009, I believe it was, and the present 2019 epidemic. They reviewed 64 studies. They found 43 that addressed infection in healthcare workers and also the risk factors. And a few of them, the majority were not on COVID-19 because there's more data on the old COVID infection, on the old coronavirus infections, but they found some information. And their conclusion is that healthcare workers accounted for a significant proportion of coronavirus infections, and they may experience a high infection rate, especially after unprotected exposures, which is not surprising. But illness severity was lower than in non-healthcare workers, and the authors attribute that mainly healthcare workers are a younger population, and they have less comorbidities than the non-healthcare workers. They also found that depression, anxiety, and psychological distress was very common in this pandemic. And there was an association between the type of exposures and getting infected with COVID-19, and the main reason was not proper use or lack of use of PPE. Now, they couldn't find any studies evaluating PPE reuse, which I think it's important because we're doing that right now. but and the highest risk was for interventions that involved intubation or direct patient contact or contact with bodily secretions. And also another important finding was that infection control training was associated with the decreased risk of healthcare workers being infected. So on this slide, what I did, I just took the information related to SARS-CoV-2 only, because the article covers SARS-CoV-1 and MERS. And the information is less robust than with the other coronavirus, as I mentioned, but endotracheal intubation seemed to be a problem, and as well as in one study, interestingly, they said that the use of N95 was associated with less risk. Now, I have not read this study in particular. I'm going to look into it because I don't know if they compare it to no mask at all or to surgical masks, and that would be an important difference. And finally, hand washing was also found to be correlated with COVID-19 infection. And there was a dose relationship. I mean, if you hand wash completely appropriately, your risk was very low. But if you start decreasing the amount of hand washing or the technique used, the risk of COVID increased. And finally, there was a study, because there was a question in one of the echoes if this could be sexually transmitted, COVID-19. And so this study done in China, they did detect SARS-CoV-2 in semen in 6 out of 38 male patients. Out of the 6 in which it was detected, 4 were in the acute stage of infection and 2 were in the recovery phase. But it has not been proven that it could be sexually transmitted. Now, having said that, you have to, it's going to be hard to know this unless someone's having sex with full PPE, because, you have to be closer than 6 feet apart, and you are exposing other more common ways of transmission beyond the sexual component. So I'm not sure how we're going to tease this one out. But there's always people with good imagination. Okay, I'll leave it there, and I'll be happy to answer any questions.
Do we have any questions for Dr. Mera?
I do have one question. How available is remdesivir at this point?
Okay, that's a great question. So I can tell you for IHS, it is available. So we got contacted a couple of weeks, or maybe a week or 2 ago, by the Oklahoma IHS, which is the one, the center here in Oklahoma of IHS. And Gilead donated remdesivir to IHS specifically. And the way they're working with us, they basically ask the different hospitals in which IHS serves, or there's at least a big Native American community or clinic close to that hospital. And they ask how many patients you have at this moment with COVID-19, and based on your response, they allocated treatments. I think that was smart because, not to receive. Right now, in our hospital, we haven't had a major issue. When they called us, we only had 1 patient admitted. So they sent us 2 full treatments. And we're just have to tell them if we have more, they can send us more. So it is available, at least in Oklahoma. IHS provided it. I assume that it's happening in other IHS sites. I know that from listening to the UNM group with Navajo, Dr. Irolu, I think they're getting it too. But I cannot vouch that everybody that needs it gets it. But I think there are resources out there to get it right now.
Thanks.
You're welcome.
Any other, excuse me, any other questions right now? If not, we can move on to Amani Ransby.
Hello, everyone. I will now provide a brief update on contact tracing as it pertains to the COVID-19 pandemic and response. Once we get these slides up. So contact tracing can best be described as a disease control measure. It involves following a multi-step process to identify potential sources of disease and probable or suspected cases. In addition, it continues to be a key strategy in decreasing or eliminating the spread of disease in outbreak settings like that of COVID-19. And I'd like to point out that contact tracing does go hand in hand with case investigation. COVID-19 case investigation consists of identifying and investigating probable and confirmed cases, while contact tracing has the primary goal of identifying and monitoring the context of probable or confirmed cases. And it also provides support to those that have been exposed and potentially infected with the virus. The contact tracing process itself starts with identification of possible or suspected cases, and it can essentially be completed in three main steps, which I will review momentarily. I would like to note that the USET TEC COVID-19 surveillance tool can assist with contact tracing and determining the true burden of disease, as the tool is equipped to capture information on suspected and lab confirmed cases. And it also includes a notes section to record information regarding the known contacts of a confirmed case. So for example, if you were to enter a record for a patient that received lab confirmation of COVID-19, then you could record information regarding the known contacts of that individual into the appropriate field. Furthermore, you could also record the REDCap record ID numbers of known contacts if they have already been entered into the tool as if to link the records. And as a reminder, the surveillance tool is housed in a secure HIPAA-compliant database system called REDCap. And if you would like to request a REDCap account and get access to this tool, then please contact us at usetepi@usetinc.org. Next slide, please. So as previously mentioned, the first step of contact tracing is to identify possible or suspected cases. Contact identification takes place once a COVID-19 case has been confirmed. And then the contacts of the infected person are identified by inquiring about their whereabouts and activities, and by also asking about the roles of potential contacts and their respective activities since the infected person became ill with COVID-19. A contact can be defined as pretty much any individual that has been in contact with a confirmed case, and this can include, but is not limited to, family, friends, coworkers, or healthcare providers. The second step of contact tracing involves creating a list of known contacts of the COVID-19 confirmed case. An effort should really be made to inform all contacts of their exposure status. Contacts should be provided with educational material on disease prevention to combat the possible threat of disease. And in addition, known contacts should also be given instructions on how to proceed, receive care, and get access to testing in the case that they do become symptomatic. The CDC does define a close contact as someone that's been within 6 feet of an infected person for at least 15 minutes, starting from 48 hours before illness onset until the time the patient is isolated. And again, contacts should be instructed to stay home, abide by social distancing guidelines, and self-monitor until 14 days from the last date of exposure. Contact follow-up is the third and final step of contact tracing. Routine follow-up should be conducted for all known contacts and should also include symptom monitoring and testing for signs of infection. Contacts should also be advised to check their temperature twice a day and look out for specific COVID-19 symptoms, such as cough or shortness of breath. I really think contact follow-up is a vital step in addressing and evaluating the impact contacts have on the outbreak, and it also provides support to healthy individuals and those potentially infected with COVID-19. So this pretty much sums up the three main contact tracing steps, but I would like to quickly direct your attention to the diagram on the slide as it gives a good depiction of contact tracing. The individuals colored in red denote those infected with a particular disease, while the white symbolizes those that are disease-free. The solid arrows denote the potential spread of infection from a confirmed case to their contacts, while the dotted lines indicate potential spread from one contact of the case to another contact. Next slide, please. So I'd like to briefly highlight some COVID-19 specific considerations when implementing contact tracing in your community. Given the nature of COVID-19 and possible asymptomatic spread, remote contact tracing efforts should be exhausted before sending contact tracers out for in-person communication and follow-up. Remote contact tracing methods can include video calling, phone calls, texting, and/or monitoring apps, and they should be utilized if available. The case definition is an important factor in contact tracing as it decides what does and does not qualify as a COVID-19 case. The USET TEC will be issuing a guidance document on the updated COVID-19 case definition per CSTE, although tribal nations may need to modify or adapt their case definition depending on testing capacity and or other known limitations that result in incomplete ascertainment of COVID-19 cases. In order to provide robust contact tracing during an outbreak, a contact tracing team or public health workforce must be built. Contact tracers can be easily trained, and they should be culturally sensitive, equipped with the appropriate interpersonal skills, background knowledge, and resources to assist tribal communities with the task of contact tracing. So that is just something to keep in mind. Technology and the use of digital tools like tablets, iPads, or laptops can also be useful when included in the contact tracing process. Such tools can be used to simply enter relevant information regarding contacts into an application, or could relay important messages via automated calls or text. Alternatively, proximity tracking tools can assist with contact ascertainment and linking. It is important to note that these tools do not mitigate the need for a task force or contact tracing team. So that is just another thing to keep in mind. Next slide, please. The diagrams outlined on this slide pretty much compare contact tracing with community monitoring. The main difference that exists between the two are that contact tracing deals with identifying contacts of known cases, while community monitoring focuses on monitoring the health of communities with infected individuals on a daily basis. Next slide, please. So I'd just like to close with some resources and trainings that may be of interest. The first two links are CDC guidance on contact tracing, and the third is a contact tracers training on train.org. And that is all I have. Thank you.
Great. Thank you so much for a great presentation. Emily had a question in the chat. If you aren't able to reach a contact, is it appropriate to leave a message that says you have been exposed to an individual who tested positive for COVID-19?
So given the circumstances, if you are not able to reach that contact, then I would say that would suffice. But you do want to make sure that they do receive that message.
Any other questions for Amani or Dr. Mira or Christy?
I have a question.
Go
Can
ahead.
you hear me?
Yes.
So in Franklin County, New York, a few weeks ago, they had I forget how many cases, but they had 93 presumptive cases, and that was during the time that people were being advised that if they had the cough, they had the fever, they had the shortness of breath, that you could make a diagnosis. So they did. And then they got a supply of PCR tests and tested the 93 presumptive cases. Of course, they were all negative by that time. So I'm wondering, have they received guidance to continue to count those cases or not? Because I just feel like it gives a false or a conflicting message about, taking precautions in that. I'm just wondering overall if there's guidance on that to the county public health systems to disregard that, or do they then reduce their number of positives? Does anybody know?
I can try to answer that question. So that they would not be lab confirmed cases, because their lab test was negative, but that doesn't necessarily mean that they did or didn't have the disease, because as we know, as time goes on, PCR is less likely to be positive. Of course, there are other reasons you can have false negatives, but it's also quite true that a lot of people are getting tested who may have some symptoms and they test negative, and they probably, a lot of those don't have COVID-19. It would be very interesting, I think, to do antibody testing on those people. I suspect a few of them at least would have positive antibodies, but I think the guidance, though, to the individual is, we don't know at this point whether having the disease confers immunity, and if so, for how long. I think Dr. Mira could probably be a lot more specific about this, but I think there's some evidence that having the disease does give a lot of people protective immunity, at least for a time, and we don't know how long. Did you have anything to add, Dr. Mira?
No, Harry, no, I agree with you. I don't.
Okay. Any other questions for the panel?
Chief Cook, you're muted, but it looks like you were talking. I'll unmute you.
Oh, okay, thanks. I think the antibody testing would be great at some point when it's more widely available, because we've only had 3 active cases on our reserve, and I think St. Lawrence County has 200 and something, and Franklin County has 100 and something, minus the 93 that were presumptive. And we've only had the 3. We have a lot of traffic. I mean, both communities, both counties travel through. But I do know anecdotally on our reserve that everybody, or not everybody, but there was a lot of sickness through January, especially February. And so that would be interesting, because a lot of people complain about symptoms. So it would just, I think we're hanging on here by our fingernails, trying to keep people still vigilant, trying to keep them to still be careful, because, we don't have any cases, and relatively speaking, Franklin and St. Lawrence County haven't had as many as other even towns, but we haven't also ever had 2 weeks of declining numbers. We always still get like another 3 in a nearby town. After 7 days of nothing, then we get 3 more cases. So I would feel better if I knew that it already passed through here, you know, and we're relatively safe. But anyway, that was what I was.
Well, you know, I think that question, so the antibody testing right now does not give us all the answers we want. Like Carrie mentioned, we don't know if you're immune or not. It's not useful for the acute illness because only 30% are positive. But I think that it's good enough, and correct me, Harry, if I'm wrong, to tell you if you've been exposed or not, because it's a very specific test. And doing probably a total antibody or an IgG, and I think total antibody would probably be better. So there's many tests out there. I would just choose a reputable company that has, look into how they validated their test. But to answer that question of, of all these a couple hundred people, how many they have been exposed, the antibody test could be useful for that. It wouldn't tell you, okay, you guys are safe, you're not going to get reinfected, because we don't know that yet. But it will give you an idea of the activity of has been the activity of the COVID-19 in your community. Right, Harry?
Correct. Yeah. Most of the antibody tests that are currently authorized with an emergency use authorization by the FDA have very high specificity. So I think most of the tests are pretty good. There are a couple that are not very good in terms of their sensitivity, but most are pretty good at picking up past infections, as long as you're, past that 2-3 week window, while the antibodies may not be detectable early on. If you're using a reference lab, most likely they're using one of the better tests that are out there. So I think if you're sending off a test to your reference lab for an antibody test, you're probably getting a good result, a reliable result.
Any final questions before we end today? I do want to draw your attention to the chat. There is the SurveyMonkey survey for today's call. If you will fill that out. And yeah. Any other questions? Okay. Well, we can go ahead and end. Have a great weekend and a great Memorial Day weekend. So, thank you all.
Hi, everybody.